programs under the Professional Development Division is Annual Midwives International Day Celebration, or we call it AMIDC. This event is celebrating two important occasions: International Day of the Midwife on May 5th and Indonesia's National Midwife Day, June 24th. AMIDC features speakers from both national and international backgrounds, offering a platform for learning, reflection, and celebration. It is my great pleasure to welcome you to this special online seminar entitled Midwives Leading the Way in High Quality Continuity of Care for Women in the celebration of International Midwives Day 2025. Today, we aim to share knowledge, explore new perspectives, and strengthen the community that supports women through some of the most important moments of their lives. Okay, before we begin, I would like to read out the rundown of our event this afternoon. First, we will have profile video viewing of Ruang Bidan Indonesia. Following that, we will proceed to our first speaker, Bu Andari Wuri Astuti, PhD. She's already with us in the room, who will be presenting on the subtopic ensuring continuity of care through early education and support. And our second speaker will be Dr. Andrew Symon, presenting on developing the QMNC Framework, a comprehensive evaluation of the quality of maternity care. After our presentation, we will continue with a panel discussion involving all speakers and participants. And finally, at the end of the session, we will have a group photo session for documentation. Are you guys excited for today? You can show your excitement through the Zoom chat below. Okay. Okay, we will go to the first session, profile video viewing of Ruang Bidan Indonesia. For operator, can you please help to show the screen? Okay, thank you, operator, for showing the video. If you guys want to know more, you can check our account on all social media platforms. I think we have Nahuda Aminat. She's saying that she is from Maldivian National University. Hello, Nahuda, and hello everyone who came across not only from Indonesia, but also around the world. Thank you so much for joining. Okay, secondly, I would like to read the CV of our moderator who will be guiding our discussion today. For operator, can you please show the CV? Okay, thank you for operator. Okay, so Kinanti is a dedicated midwife. She is based in Sorong City, Southwest Papua, Indonesia. She is a graduate of the Health Polytechnic of the Ministry of Health, Sorong, Indonesia. Kinanti has a strong passion for maternal and child health and brings hands-on experience from various health centers and hospitals. She has contributed to health innovation through research, skilled in communication, data analysis, and public speaking. She also received several achievements, including second best speaker at ICUHPS conference and multiple competition wins. Currently, she works at Lentera Medical Clinic and continues her involvement in public health and midwifery. I think Kinanti is already with us. Kinanti, okay, Kinanti, how are you today?
Hello, Raihana. I'm good today. Thank you for asking me. How about you?
Yeah, I'm great. Are you excited for today, Kinanti?
Yeah, really, really excited.
Okay, I will give the time to you, Kinan.
All right. Thank you so much, Raihana. Thank you so much for the kind introduction, Raihana. I am Kinan as Professional Development Ruang Bidan Indonesia, and I will be the moderator for today's webinar. Good afternoon from Indonesia, good morning, and good evening for all the participants overseas. Thank you for coming. Hope you're having a good day with us. And welcome to annual Midwives Day celebration. Also, happy International Day of the Midwife and Happy International Day, Happy International of Mother's Day. Today, we will discuss more about midwives leading the way in high quality continuity of care for women. So before we are started, let's get to know each other. Where are in the world are you joining us from? Please comment in the chat Zoom below. So excited for today's webinar because we have the participants from around the world, such as Indonesia, Bali, Central Java in Indonesia, Surabaya. Thank you so much for coming online with us today. Hello, Madiun. Thank you so much for joining us with Ruang Bidan Indonesia. So let's see how your excitement, guys. Choose your emoticon or reaction in the Zoom. Thank you. Before we start into the speaker session, let me explain the specific rules briefly. I will inform you that each speaker will have 3 sessions. First is presentation in 30 minutes, continued by Q&A session over the panel discussion in 45 minutes. And for the last is documentation. We turn on the English caption to help you. If you need any help, please let us know. For the Q&A session, we will start with the 3 raised hand participants to give the question directly to the speaker, and you can write down your question during the speaker presentation in the chat box. Saya ulangi, masing-masing speaker akan mendapatkan 3 sesi, yaitu yang pertama presentasi dalam 30 menit, dan dilanjutkan dengan sesi tanya jawab melalui panel diskusi selama 45 menit, dan yang terakhir adalah sesi dokumentasi. Kami mengaktifkan transkrip dalam bahasa Inggris untuk memudahkan kita semua, dan jika kalian memiliki pertanyaan atau membutuhkan bantuan, tolong beritahu kami. Dan pada sesi tanya jawab, kami akan memulai dengan 3 penanya pertama yang akan memberikan pertanyaan langsung kepada speaker. So without any further ado, let's jump to our core webinar, which is sharing session. Ruang Bidan Indonesia invited 3 special speakers who will bring a wealth of knowledge and experience in midwifery care. They are a gorgeous midwife from their home base. So the first is we have Dr. Andari Wuri Astuti, and for the second we have Dr. Symon, and for the last is we have Laksmi Tamang. Unfortunately, Laksmi Tamang cannot join in online with us today because on her duties in ICM. So make sure you join the webinar until the end of the session. Each speaker will explain more about high quality continuity of care in different topic. Let's start with the first speaker. Operator, please, can you share of Bu Andari's curriculum vitae? So we are take a look on the screens together, guys. It is my pleasure to introduce Bu Andari Wuri Astuti. She is senior lecturer at the University of Yogyakarta, Indonesia. She was born in May 13, 1985. Currently, her position as head of Master of Midwives Study Program in Aisyiyah, University of Yogyakarta, Indonesia. She published a lot of journal in reproductive health. And if you're wondering more about her publication, you can jump into her account such as Orchid, Scholar, and more. So today she will be presenting about ensuring continuity of care through early education and support. And she also receiving a lot of awards. Let's welcome her together because we already have Bu Andari in the Zoom. Hello, Bu Andari.
Halo, ya, Assalamualaikum everyone.
Waalaikumsalam warahmatullahi wabarakatuh. Bu, how are you, Bu?
Yeah, I'm good. Thank you for asking. How are you?
I'm good.
Right.
Thank you for having me as moderator. We are excited to have you online with us today, Bu.
Yeah, I'm also beyond excited, I think, because I can see you guys in here, very young generations of midwives that really have, very passionate, yeah, for having this session. So yeah, really glad for that.
Today, we will level up with Bu Andari Wuri Astuti. So, Bu Andari, would you like we can or you share your screen or we can help you?
Well, I can do by my own. It's okay.
Okay, let me remind you again that your presentation is 30 minutes and we will continue by panel discussion for 45 minutes. Is that okay?
Well, I just asked with Mbak Mutiara that because I have a very limited time, so maybe after my speech, that will be a discussion for maybe 5 or until 10 minutes, and then I can. I'm so sorry. I need to leave due to the work commitment, another work commitment to do. So yeah, if it is fine.
All right, is it okay? It's fine. So before we next with Bu Andari presentation, I would like to capture this moment with you, Bu.
Yeah, sure.
Ladies and gentlemen, please open your camera because I want to see your best smile. Operator, please capture this moment. All right, I will count 1, 2, 3, and everybody smile. 1, 2, 3. All right, thank you so much. Ladies and gentlemen, I present to you Bu Andari Wuri Astuti. Time and screen are yours.
Right, but I cannot share my screen because if the host can able me to share the screen, please.
Operator, please make Bu Andari as a co-host. All right. Please wait.
Now it's okay now. Yeah.
Okay.
It's working now. Right.
It's working.
Right. Can you see my screen now?
Yep, I can see it.
Right. Okay. So I will start. Good afternoon, everyone. If you are in Indonesia, but if you are in somewhere else, maybe it's different time. So this is really glad to see you in this screen for having very young generations that really passionate with midwife. And today, I really appreciate for all the committee that initiate the program and for celebrating the Midwives Day. Yeah. So for everyone that joining today's sessions, I will say happy International Midwifery Day. Yeah. And for the National Day, we will have it in June, right? So yeah, really looking forward for the national one. And today, as a request by the committee, that the committee asked me to present the topic about ensuring continuity of care through early education and support. And here we are, yeah. So there will be four things that we will discuss in next 30 minutes. First will be about introductions, about what is continuity of care and things like that. And then after that, followed by concept of continuity of care. And then will be followed by role of early educations, importance of early support system. And then after that, we will also discuss about strategies to strengthen continuity through education and support, and also the last will be recommendations and future directions. So this is the aim of the presentations that will be highlighting how early education and support system ensure sustained quality care across the continuum of care. And I guess most of you are midwives, or maybe midwives soon to be, yeah, which is students of midwife. So we might review about what is actually continuity of care. So continuity of care itself is defined as the consistent and coordinated delivery of health services to a patient over time and across different levels or providers of care, and it ensures that care is connected, coherent, and responsive to a patient's evolving needs. That will be then consequence of that will be promote better health outcomes, patient satisfactions, and system efficiency. And how about the continuity of care itself in midwifery? So it refers to a model of maternity care where a woman receives services from same midwife or maybe small group of non-midwives, yeah. So it's not only one, but in some of the contexts, there are a group, yeah, small group of non-midwives throughout the continuum of a pregnancy, childbirth, and the postnatal period. So in this definitions is clear that continuity of care in midwifery will be a model of maternity care, and it will be provided by midwife or midwives, yeah, midwives in a small group during pregnancy, childbirth, and the postnatal period. And even when we talk about pregnancy, childbirth, and the postnatal period, so when we saying about the continuum of care, so it will be we can then highlight it that we need also to provide the care before the pregnancy happen. So this kind of this is something that we need to highlight, that the continuum of pregnancy, childbirth, and the postnatal period need to be prepared before the pregnancies occur. So what is the key feature of continuity of care in midwifery? So first will be about rational continuity. So this is a trusting and ongoing relationship is built between the midwife and the woman. So why the continuity of care is important? Because the rational continuity is the relationship. So in here we can highlight that when we provide continuity of care for the woman, so first one that need to be highlighted is trust, yeah, because we need to build the relationship, yeah, between midwives and the woman. And the second one is about consistency in care. So the same midwife or team providers antenatal, intrapartum, and postnatal care. Why it needs to be consistent with the same midwife or the small group of midwives? That's because that will be make benefit for the woman because they will not having redundancy informations, because if they meet with the new one, then they need to provide new things again. So then that will be make the easier for the midwives and also the woman to discuss about what the issues that they need to concern. And the third one is the feature is the woman-centered care. So what is the woman-centered care? So this care is emphasized and personalized, respectful and culturally insensitive support. Yeah, because you know, when you are centered with the woman, so all what you provide for the woman is focusing on the woman, not for the healthcare providers. Yeah, so that's why this woman-centered care then will be very personalized, because everybody is unique. Yeah, respectful, because we need to respect to give the respectful midwifery care for them. Yeah, and culturally sensitive, because not everyone has the same values. Yeah, and this not everyone has the same culture. So in here, yeah, we need to culturally sensitive, giving the culturally sensitive support. That's all the key features of continuity of care in midwifery, that the aim of that is improve outcome. So why is because research show that reduced interventions rate, higher satisfactions, and better maternal and neonatal health outcome will are the outcome of continuity of care in midwifery. So when you conducting the continuity of care in midwifery, so the benefit of that is improved outcome. Yeah, for example, reduce interventions rate, and then the women also have higher satisfactions on their experiences of pregnancies, childbirth, and also postnatal, and also have consequences on better maternal and neonatal outcome. So this is the benefit of continuity of care in midwifery. Yeah, as I mentioned before, this kind of increased maternal and confidence and satisfactions, that also makes lower rates of preterm birth and neonatal death, enhance communications and trust, greater likelihood of spontaneous vaginal birth, because they trust that midwife will help them. And then also have enough preparation for handling, for example, fear, and then handling their anxiety. So this also kind of important matters to the woman for their preparations on a spontaneous vaginal birth. And here is the concept of continuity of care. So is first one is informational continuity. So actually, and that concept for the continuity of care is transfer of patients' informations across providers. Yeah, because in here, if we are a midwife, so the patient will be the woman. So within the small group, then we can then transfer what are the conditions of the patients or women in order to make easier for all the group. Yeah, so they need to communicate each other, transfer knowledge to each other. And the second one, the important things is also relational continuity. Yeah, ongoing relationship between patient and provider, and management continuity. So this is need to be consistent and coherent care planning and executions. So what is then early educations that we discussed I said before. So early educations in the context of healthcare and continuity of care refers to the proactive provisions of knowledge, skills, and support at the earliest possible stage, either in a person's life or at the beginning of their interactions with the healthcare system, in order to promote informed decisions making, self-care, and active participation in health management. So early education is kind of, health educations before pregnancies, if it is in midwifery care, for example. So yeah, so early educations typically in midwifery and maternal health is called preconceptions educations. Yeah, that teach individuals or couples about reproductive health, nutrition, and family planning before pregnancies, in order them to get very ready, yeah, and have enough preparations to engaging pregnancies and their family livelihood. Yeah, because family and fatherhood and also motherhood is, is kind of also challenging for those who are not preparing before. Yeah. So in this preconception education, there's also one of the benefit of that. And the second one is antenatal education. So informing pregnant women about pregnancy changes, danger signs, birth preparedness, breastfeeding, and newborn care. So in the antenatal education, so informing and preparing them to get ready, yeah, to be a mother, or preparing them to, managing their anxiety, yeah, maybe, and also, improving their self-efficacy for their birth is also one of the early educations that you can do. And the third one is provider education. So introducing healthcare professional early in their training to key principles like continuity of care, respectful maternity care, and holistic approach. So in here, yeah, early education is also kind of, is also given to provider education. So we as a midwife is also, you can also have an early education about this thing, yeah, and it also can be called as an early education. So the purpose of the early education is to prevent complications through early awareness and behavior change, to empower women and their family to take charge of their health, to equip providers with foundational knowledge and attitude that support long-term quality care. Of course, yeah, if you then give the educations, yeah, adequate educations, adequate knowledge, adequate informations to the woman, then they will know their conditions. When they know their condition, they might have less anxiety, yeah, about what happened, with their body during pregnancy, during childbirth, and during their parenthood. So next one is about role of early education for midwife. So this also can building core competency. So this can be role of education for midwife is building core competency. So understanding physiological and psychosocial aspect of pregnancy, childbirth, and postnatal period, mastering skills in assessment, decisions making, and timely referral, and also developing competence in providing woman-centered and evidence-based care. That, of course, yeah, this is also very important in our service as a midwife. And also, the role of early education for midwives is promoting continuity of care by introducing the importance of relational, informational, and management continuity. And also, this can encourage the woman having long-term engagement, yeah, before pregnancies occur until the baby is growing up, yeah. And the third one is enhancing communications and cultural sensitivity, yeah, because training the healthcare provider in effective communications will be support them, yeah, to provide the care with the autonomy, yeah. And also this can also promoting cultural competence to respect diverse belief, practice, and also need. So please, moderator, yeah, if for example I just go beyond the time, just please let me know. And third one is strengthening professional identity, yeah, and also supporting collaborative practice. So in here is the role of education for women, family, and communities. Of course, this can be also a part of health literacy promotion. So empowering individuals with knowledge to understand, navigate, and manage their health effectively. And then preconceptions and antenatal educations are providing early guidance on nutrition, birth preparedness, danger sign, and newborn care, and also community awareness program, yeah, raising public understanding of the importance of sustained and coordinated care through outreach, workshops, and a local campaign. And importance of early support system now. Yeah, we are moving on to the importance of early support system. So in the continuity of care, support system and family involvement are also aspect that need to be highlighted and very important for the midwife. Yeah, so peer support group foster shared experiences, emotional reassurance, and practical advice. So usually, yeah, when a woman talk to their peer, yeah, they will be very freely express their experience. So their experience then can be, adopt or adapt, yeah, by the peers, yeah, and they can share best practice, yeah, of with their experience, so they can share best practice that you can then that can guide other member, yeah, when they have a similar problem. And the second one is about family involvement, yeah, enhance care adherence and reinforce healthy behavior at home, yeah, because as a midwife we cannot accompany them through all the time, yeah. So we can then involve the family as the support system for the woman, yeah. We need to educate them as well, yeah. And also we need to counseling service, yeah, that also address mental health, stress, and decision making during pregnancies and postpartum. And the second one is the role of health worker. Yeah, so midwives, nurses, and community health workers play a front line role. Yeah, in the continuity of care of in midwifery. So why? Because they then will be take a role on early detections and complications. Yeah, health educations and promotions, continuous monitoring and home visit, and also facilitating referral and feedback care levels when something happened. And also we are not going to leave technology, of course, because now we are living with technology. So mHealth, telemedicine, and digital reminders can also need to be considered for us when we are conducting continuity of care in midwifery. And this can also help the midwives, yeah, to optimizing their work as a midwife to continue continuity of care. And now it's about how about the strategies to strengthen continuity through education and support. One, we need to interdisciplinary education and collaboration. So integrate continuity of care concept across midwifery, nursing, and medical curricula. Yeah, there will be aspect that very important. Yeah, for strengthening continuity through education and support. And also it can promote collaborative training programs to enhance teamwork and share responsibility. The second one is strengthening referral and feedback mechanism. So develop a clear, timely communications pathway between primary, secondary, and tertiary care. Will then support continuity through education and support. And also we need to ensure directional feedback loops between facilities and community-based provider. We can also enhancing post-discharge follow-up, yeah. For example, establish structured home visit program or digital follow-up protocol if we are going to use the technology, engage community health worker and midwives in continuity beyond the facility, for example. And also we need to empower women and families to provide early education to support informed decisions and self-care, because we are not going to, accompany them 24 hours. So then we need to educate them to having the self-care. Yeah, if something happened, then they can conduct something that they can do by their own first. Yeah, and then promote shared decisions making in birth planning and postpartum care. Yeah, and leveraging digital health solution, as I mentioned before. Yeah, we can use technologies such as mobile applications, and then such message service alert. Yeah, teleconsultations for ongoing education and monitoring, and etc. And the last one is about supportive policies and institutional commitment, because embed continuity of care goals in health system policies and service delivery model will be very important in order to support and to help the midwives to conduct their continuity of care service. And then also, of course, we need to allocate resource for training, supervision, and technology deployment. So that's all my presentations for today. I think I'm not going beyond the time, right? And after that, we can have a discussions because I'm so sorry I cannot, join until the end of the sessions due to the another working commitment. So yeah, please, if you have any questions.
Thank you so much for your thoughtful presentation, Bu Andari. Now we will open for the three raised hand from the participant who wants to give the question directly to the speaker. Anyone? All right, we already have Husnul Fadila. You still mute?
Okay.
Okay, we can hear your voice. Yep, Husnul Fadila, please deliver your question.
Okay, thank you, Bu Andari, for your explanation for the. So I want to give a questions about your presentations. Wait.
We're still waiting for your question. Take your
Okay.
time.
Okay. What Bu Andari, I want to ask questions about it. You can say that how can a midwife provide a health education to women from an early age? I see that the education's curriculum in Indonesia so far has only focused on the academic value, while the health aspect of children, adolescents, and especially women can be said to be only considered after a disturbance or extraordinary event. Those do not understand the reproductive organs and don't even understand the biological change in themselves. Understanding about the sex is only limited to sexual intercourse, not educations about health sexuality. So please pay attention so that high quality continuity of care for women is not just a discourse and little. Okay, thank you.
Right, sorry, Husnul. So if you can chat maybe with your questions, because I think I'm still not, I'm not clear with
Get it?
So what is your questions then?
Okay.
Okay, I think Husnul Fadila will write her question in the chat and we will move on to the next participant.
Yeah.
Thank you, Andari and Kinan.
Yeah, please write your question in the Zoom chat, Husnul. We have a question from Reski Regina in the Zoom chat. I will read it to you. How we can create or improve referrals and feedback among hospital and primary healthcare? Any example for this? And how to get feedback from primary healthcare for patients with preeclampsia?
Okay, so this is maybe first one by one, yeah, because it is about continuity of care, and then the questions is about the referral system. So the referral system that need to be strengthened, I think, is kind of you need to having communications between those who are working in the primary healthcare, and then after that going to hospital need to also communicate, yeah, with with the midwives there, yeah, about the patient's conditions. But the problem in Indonesia now, sometimes when we are rural, then sometimes is not having a good communication for that due to several reasons. So I will give the good example for this, yeah, for the process of continuity of care, for example, in Australia, for example. So the midwives, when the woman need to be referred to the hospital, for example, due to the complications, they need to be still be beside of the patient. So it's not kind of then it is give by the another person, but the midwife will continue carrying the woman in that hospital. So the system allowed that, but in Indonesia we are not allowed for that. So this is the problem, and I think this is kind of need to be discussed about that and need to be more study about how it will be kind of one of reference that can be adopted in Indonesia. Yeah, I think that's I can answer.
Well, Reski, that is the answer from Bu Andari. Any comment? All right, I think there is no comment about it. Thank you, Bu Andari. Now we have opportunity for our participant to ask the question directly to the speaker. Please raise your hand if you have a question. Or we have a couple of questions from Google Form. I will read it to you, Bu Andari.
Okay.
This question is from Regis. No, this question is from Ade Suryani. What are the success indicator of early education and support program in the context of continuity of care?
Sorry, what is
the what is it? What are the success indicators of early education?
what are the
success,
okay?
yeah, the success indicators of early education and support programs in the context of continuity of care.
All right. Okay. Of course, the success indicator is when the feedback from the patients or the women are high. So they have a higher satisfaction for their experience during pregnancy, childbirth, and also and also engaging parenthood, for example. You can also the indicator that you can see is they they can trust the midwife, for example. They can, the family will be involved with our family for the continuity of care. I think that's a lot, yeah, for the successive indicator, yeah, for this continuity of care. But then we can see from the woman perspective, their satisfaction will be also one of the indicator that you can also measure. Yeah.
Yep, I agree that bonding with community is really important.
Yeah.
So we still have a couple of questions from Isnaf Khalida. How can midwives provide health education to women from an early age?
Sorry.
How can midwives provide health education to women from an early age?
Okay, so for the girls, do you mean?
Yep.
For the girls, yeah. For the girls. So for the girls in young age, do you mean?
Yep, in early age, because there is no curricula in Indonesia.
Okay, for the sexual reproductive health.
Yeah, Ibu.
Yeah. So this thing is, I think, is very good question. So why it also need to be discussed about the sexual reproductive health during their from their early age, because actually the strategies to provide them is giving the information based on their age. So then if something, for example, in your early age, when you are having a kind of toddler, yeah, you can start with something that, for example, private, private part of your body, for example, that cannot be seen by other, for example, like that. So then you can educate them with things like that, in a very simple way. Why? Because the kids, they are not having kind of, not yet having, how I can say, yeah, we cannot give them too much education, yeah, too much education. So we need, when we giving this sexual reproductive health for the kids, we need to, consider their age. So, for example,
There's limitation.
yeah, because they have a limitations to understand, right? Not like adult. So you need to start with very simple way in a proper matters, for example, and also you need to consider with their language, yeah, with the language, because if it is very complicated language, so they also cannot, cannot understand what you mean, for example, like that. So I agree that we need to build the awareness of the sexual reproductive health. Start from the beginning of, from the early age, yeah, because this will be very important for them, yeah, to understand, yeah, when people, doing kind of something that make them dangerous in their sexual and reproductive health, then they can decide something. For example, we can say to them, when when somebody trying to touch your private, then you can, shouting and trying to asking help, for example, something like that. So this, I think, can be understand, yeah, by the kids.
Yeah, that I really agree that we can start from our private part body and with child language. Any question from participant? Yeah, Husno?
Okay, thank you, Jenny. Thank you, Bu Andari, for your insightful presentations about the continuity of care. It's very insightful for me. So I would like to ask a questions about that. What we should do as a young midwifery relate to educate in the posyandu remaja. And it's a posyandu remaja.
Yeah. So what
what we should do as a young midwifery relate to educate in the posyandu remaja. Thank you, Bu Andari.
Do you mean that as a young midwife, so what should you do? Something like that?
Yes.
All right. Okay. Well,
Thank you, Bu Andari.
if you provide a care, yeah, as a young midwife, you need to also learn from your senior one, yeah, because I think they already have a work plan to do, and you can then, as a young midwife, you need to be very innovative, yeah, and then you can also provide some of the program that you can also suggest for to strengthening the program, yeah, for your program to support, yeah, to support the program in your work, I think. Yeah.
Okay, thank you, Husno, for your question. I think you get it. Okay, because the limitation of the time, if you guys wondering more present about from Bu Andari Wuri Astuti, you can jump into her social media, such as LinkedIn, Instagram, and more. So making connection with her. So Bu Andari, I would like to invite you to giving us closing statement.
Right. Okay.
Please.
So yeah, the closing statement will be, you guys as a young midwife, I think you are the next future generations that can conducting the continuity of care to improve the high quality care for the midwives, and the aim of as the aim of the continuity of care is to improve the maternal and newborn health. I think that's all my closing statement.
All right, thank you so much, Bu Andari.
So
Thank you
yeah,
so much.
right. Okay.
I hope you have a good day with us today. Thank you so much for your insightful.
Yeah.
Let's meet in another event.
Yeah, right. Okay, so thank you very much. So Kinan, yeah, actually my daughter is called Kinan as well. So I just
Oh,
yeah. So yeah, thank you everyone. I really enjoyed the sessions, and I really appreciate for you to to managing this very good event. Yeah. So I'm sorry I need to leave. So, and hopefully after this you also have very good insight material from another speaker. So I need to leave. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Ibu.
Thank you.
Bye. All right, that's all from our first speaker, Bu Andari. Really really give us insightful presentations. Now we will move on to our second speaker, Dr. Andre Symon. Please, operator, can you share the curriculum vitae of Andre Symon? All right, we can take a look on the screen together. It is my pleasure to introduce you about Andre Symon. He is senior lecturer in the Mother and Infant Research Unit at the University of Dundee in Scotland. He qualified as midwife in 1986 and has worked in both Scotland and Kenya. Since 2016, he has been working on developing the quality maternal and newborn care QMNC framework as a data collection tool. First for qualitative research and more recently as a survey, the QMNC Framework Index. He has presented this research in several countries such as in Arabic, Chinese, Portuguese, and more. To date, this research from 40 other countries, including Indonesia. Wow, we're excited. So this already translated into Indonesia, and Andre is an adjunct professor at the University of Technology in Sydney. I think we already with Andre Symon in the Zoom. Let's welcome him together. Hello, Andre. It's great to see you.
Thank you very much, Kenan, for the opportunity to talk to your conference today. I hope you've had a good day to start, and we look forward to it continuing well.
Well, thank you so much. So, Andre, how can I call you? Andre or Symon?
Andrew is fine. Andrew
is fine. Thank you. Yeah. You can call me Kinan too.
Kinan, thank you.
All right. Let me remind you again that your presentation will be 30 minutes and we will next do question and answer. Is that all right? Is that okay?
So are we going to question and answer now, or will I do my talk now?
We have the presentation first in 30 minutes.
Okay. Right. I'll try and share my screen.
All right.
If this works.
All right. Please let us know if you need any help.
Oh, hang on. Okay.
Ladies and gentlemen, we are still waiting for Andre to share his screen. All right, I can see it.
Can you see that now?
Yeah, I can see it.
Okay, that's great. Okay.
Ladies and gentlemen, I present to you Andre Symon. Time and screen are yours.
Okay, thank you very much. And good afternoon to you. It's morning here in Scotland at the moment. But thank you for the invitation to come along and talk to your conference today. And I note that you're talking about continuity of care, which is so important, really important in terms of improving outcomes rather. So what I want to talk to you about this afternoon is in the QMNC Framework Index, Now, QMNC, I'll explain what that stands for in a minute. It's a fairly long title, but this is a quality of care evaluation. And at the moment, we have service users, that's to say, mothers, new mothers, evaluate the quality of care. I'll explain a bit about the story behind that as well. It's been several years in the making, and I should just introduce our validation team here, who came from 4 countries for the fieldwork. From Ghana, Samuel Ajulolo and Caroline Badzi; from India, Manju Chugani and Renu Karb; from Australia, Alison Cummins and Elise Prusson; and in Scotland, myself and Nicola Gray and Alison McFadden from the University of Dundee. And we also had statistical support and other support from Norway, from Berit Mortensen and Ari Hugo Pripp, he was the statistician. So we have a multinational study that validated the QMNC Framework Index. But this is just the end of a long story in terms of developing the QMNC Framework. I hope you know the QMNC Framework. It was published just over 10 years ago in the Lancet series on midwifery. And it was a synthesis of all the evidence around the world on what constitutes quality care. In other words, what aspects of care produce the best outcomes for mothers and babies. And I should have said at the start, I'm sorry, if I will try and speak slowly enough, because I understand it can be difficult hearing people speak with a slightly different voice. So I'll try and speak slowly, but if it's a problem, please somebody just flag up and tell me to slow down. But this is the QMNC Framework Index, which is arranged into 5 rows, which are called components of care. And the text which is in the box are noted as characteristics. And you'll see that continuity is one of those characteristics of care, and that's how you organize care. Now, you know from your conference today that continuity is really important, and it really is important that if you improve continuity of care, and especially of carer, then you improve outcomes for mothers and babies. So it's really important. Now, this is the framework, the Quality Maternal and Newborn Care, that's to say QMNC framework. And what it noted in this Lancet series was that all women should get almost everything. They get everything except that little box in the top right-hand corner, which some women need if they have complications, and some babies need if they have complications. But since all women should get all of that, we started with the theory, the idea that it made sense to evaluate maternity care according to whether it fits into those characteristics, it meets those characteristics, those criteria about what quality care actually looks like. So we started about 8 or more years ago with some qualitative work, and we transformed the framework into a focus group topic guide to find out what works and how it works and why it works and who it works for. So for example, we looked at values, the component of care of values, which is about respect and communication and tailored care. And we asked a question: do you feel that women are shown respect within this model of care? And a subsidiary question, for example, was care tailored to the needs of individuals? Now, this is for service users, and we also asked service providers. We interviewed midwives and obstetricians, as well as pregnant women and new mothers. So that was an example of how we transformed the framework into a focus group topic guide for use in qualitative research. And we conducted that first study. It was called the McTempo study in Tayside and Fife, which is the region where I am in Scotland. And you can see that those are my colleagues on this one. Alison McFadden and the others are my colleagues. Alison Cummins was a visiting Australian midwife academic. She came to Scotland for a few months and worked with us for a while on this project, and she liked it so much, she took it back home to Australia. And so, in fact, over time, we conducted 4 focus group studies, 2 in Scotland and 2 in Australia. And these were all very successful. They all found out, enabled us to drill down and find out in a qualitative research what works and what doesn't work in terms of quality care. In other words, where are we doing well? Where are we not doing well, according to midwives and obstetricians and pregnant women and new mothers. So it's quite comprehensive, and we had 4 good-sized qualitative studies. And we published these in these journals, as you can see. But we realized that if we want to evaluate at scale, we have to move beyond qualitative research. So we had to create a survey version of the framework rather. And this gives us an opportunity to combine research, to have a quantitative research and the qualitative research nested in with each other. And this is the way we're actually advising people to do this. If they want to follow our research, to do a survey and then do follow-up interviews, because then you can drill down and investigate your results. So it's an opportunity to combine qualitative and quantitative approach. Now, meanwhile, various other people were very interested in developing the work of the QMNC framework. And in 2019, in Kentucky, in America, I was part of a group which launched the QMNC Research Alliance. And this is a group of midwives, sociologists, statisticians, service user advocates, and there may be some others who are interested in developing the framework so that we can help to harness its power, because it's a very strong tool that tells you what quality care looks like. And they posed themselves some questions saying, well, what are the questions that we really need to be asking, particularly in midwifery research? And that's my background. I qualified and I practiced as a midwife, and I've been in the university sector doing research and teaching for a number of years. What this the Research Alliance came up with was 3 research priorities. And these are, broadly speaking, to do with models of care, to do with epigenetics, and to do with outcomes. Now, my own angle on this one is particularly research priority A. In other words, it's how effective is midwifery care. So I'm particularly interested in models of care. And this work, for me, goes back over 15 years. I've been looking at models of care for a long time now. We're also interested in which outcomes are most important. And while we know in maternity care generally, we can measure hard outcomes, you measure death rates, serious morbidity rates, we can count these things quite easily, but we're aware that there may be other outcomes that we really need to be using and measuring and assessing our care on. And it moves beyond mere satisfaction, because that's quite a problematic concept, in fact. So I'm interested in models of care and also about which outcomes are the most important. Excuse me. So for our quantitative approach, we developed this prototype survey based on the framework. And the framework, as you remember from that diagram, is very, very full. There's lots of things, and there was a huge amount of work that went into developing that framework. And we developed a prototype framework index. And this we did through a modified Delphi approach. And we published the process of this in the journal Birth in 2022. And that's Alison Cummins, the Australian midwife academic, and myself were leading on this part of the research. So we developed a prototype QMNC framework index. And these were the participants for our modified Delphi study. And you could see that they came from many different countries around the world. It would have been even more countries, because we had people invited from several other countries who agreed to be part of our Delphi expert panel. And then COVID came along, and for many people, their priorities had just changed. Their workload had to change, and they weren't able to take part. But we still had 25 international experts from quite a wide range across the world. So we were quite pleased with that. The Delphi process, I don't know if you're maybe familiar with this one, but it involves starting off with a prototype, in our case, a survey instrument, sending it out to the panel. They give you feedback. You modify as you need to. You then send it back to the panel, and they check it again, and you can go through a third round. And we had a slightly different third round where we used 2 experts in survey design. And the process was that actually our questionnaire grew in length, as you can see, from 33 questions, then up to 75, then up to 85. And I knew that was potentially a problem. It did then become the draft QMNC Framework Index, and that was what we had to try and validate. It maps, of course, across to the QMNC framework itself, the practice categories, organisation of care, the values and philosophy, and the care providers themselves. So we had proof of principle from the qualitative studies. We knew that you can do focus groups and individual interviews, and you can drill down and ask people what works and what doesn't work. So you can get good information on care quality in different settings. We produced the initial draft questionnaire, we'd done the Delphi survey, and next we had to field test this prototype in diverse settings. As you can see, we used Scotland and Ghana and India and Australia, and added to that, as I said, came the team from Norway, the Midred team, led by Professor Berit Mortensen. So our aim was to see, can we validate the QMNC Framework Index? And as I said before, this addresses research priority A, the models of care, and it touches also on outcomes of care. So the target population for our survey is women who'd given birth in the previous year. Now, we decided to start this at 6 weeks, not to do the first 6 weeks. There's good reasons for this. If you conduct a survey very soon after the birth, you tend to find you get extremely positive answers, because by and large, if mother and baby are both healthy and well, then women tend to report everything was fine. But if you wait a little bit longer, you tend to get a more reflective and probably more accurate assessment about how things went during pregnancy, during the birth, and after the birth. So our target population was 6 to 52 weeks postpartum. And our primary objective was to try and validate the QMNC Framework Index to establish its construct validity and its reliability. If that all worked, we wanted to assess the feasibility of conducting it in a range of different settings. And we had these settings in India, in Ghana, in Australia, and in Scotland. And then if all of that works well, to see, can we do some associations between key variables and quality of care scores, just as an exploration. What happened in our first run, the 2022 survey, was that we got over 900 responses, very good response rate in Ghana and India. Women there were recruited face-to-face in a postnatal clinic, usually a vaccination clinic. So babies would be brought for vaccination between 6 to 8 weeks postpartum, and the mothers would be recruited and interviewed in the clinic. But they completed the form online using a tablet that was provided for them in the clinic. In Scotland and in Australia, we didn't recruit online. This was partly because we were still in COVID times and our clinics were severely disrupted. And so we decided we had to go online, and we used various women's groups, advocacy groups like the Wellbeing, the Women's Fund, the Daisy Foundation, Maternity Voices Partnership, and so on. So we recruited online in Scotland and in Australia, and you can see that the numbers weren't quite as good, particularly in Australia. We had some thank you vouchers in each country, a lucky draw to try and encourage participation. What we found, the results from that survey, was that the Cronbach's alpha, which is how you measure your consistency, the consistency of a survey, were actually good or very good in all parts except for the management of complications. And that was only completed by a minority, well under half of the respondents. And so statistically, that's more of a problem. So that was a little bit of an issue, although the rest of it was very good. But we also found that several of the items were either repetitive or actually just not operationally useful. And it was really good to do that first run of the validation. We hope to do it in one go, but that's not always the way things work out. So what we ended up doing was significantly shortening the survey form. From the 85 questions, we got down to 44, so just about half. And it still maps across to the QMNC framework very, very carefully. But it was now a much tighter one. And I was actually personally quite pleased that it was a much shorter form, because I think asking women to complete a lengthy survey is potentially quite difficult. So we had then to test the redrafted framework index using the same 4 countries. So in 2023, we started again. Now, this is what the content of the survey looks like. It's based broken down into 5 parts, each of which are divided into subsections. So we have care providers, the care providers' values, the care received, organisation of care, management of complications. And this really does map across to the framework itself. Here we are. So care providers maps across to care providers, as you can see. Care providers values maps across to values and philosophy. We found that in practice, those actually were they intermingled. They were quite similar. The care received was mostly about practice categories, but it also reflected other things. The organization of care maps to organization of care, and the management of complications. You can see maps to those two pink squares in the top right of the framework itself, which is about managing complications, both first level management and management of more serious complications. We also realized that we had to draw a distinction between the first 4 parts of the survey and the final part, which was the management of complications, because again, only a small minority of women completed that one. So we have to treat that as a separate sub-index. So what the questions look like, for example, some questions were broken down into A, B, and C to reflect pregnancy, labor and birth, and postnatal. So some questions were actually triple questions, which does lengthen the form a little bit. Most questions offered Likert scale response options. So for example, strongly agree to strongly disagree, or in some cases, depending on the question, all of the time to never. This, you understand how Likert scale responses work. So we repeated the survey in 2023. It ran into 2024 because we encountered bureaucratic hurdles in one of the countries where, and this is real world research, the ethics application just got stuck, which was very odd because it was the same studies that we'd done before. It had previously been passed, and yet in one country, they just couldn't get past the ethics committee because people were off sick, and it just got delayed by 8 months. So it ran into 2024. But the same team as in the first run, the same target population. The sample size calculation from the first run meant that we know we didn't need as many people, as many women to fill it, because partly it was a shorter form, so you don't need as many respondents, but also we realized from the strength of the first analysis that actually we could do with far less. So we aimed to get 120 in each country. And as you can see, we very successfully recruited that in each country. And again, the same kind of recruitment in Ghana and in India, online, but with face-to-face recruitment in a postnatal clinic, in Scotland and in Australia, online with the same targeted and snowball sampling. So we got over 500, we got 540. And in terms of the statistical analysis, the validity was good. Cronbach's alpha for 12 of the 13 sections is extremely good. What you want is a score that's above 0.7. And 12 of the 13 sections, it was well above that. So that's extremely good from the validity. The reliability, 55 women completed the survey a second time, 2 to 3 weeks afterwards, and you measure how stable an instrument is this way. So if you get very consistent responses over time, then you say that the tool is valid, is reliable rather. And reliability was good. The average kappa across 13 sections was very high. Again, you look anything above 0.6 is pretty good, but we went much higher in most cases than that. So the tool is stable over time, which is good. That's a very good sign of strength of a survey. So the only exception to our very high Cronbach's alpha, you can see here, was the in care received support during labor, which had 5 questions. And you can see that the Cronbach's alpha was 0.594, which is a little disappointing. And we looked very hard at why this might be lower than all the other areas. And we tried taking one or other question out just to see, does that affect it? Is it a particular question that's drawing it down? And it wasn't any one question. Now, we looked, to us, the questions all look like they really do belong together. They're all about support during labor. But for some reason, and it may simply be statistical artifact, you do get these things sometimes. So we considered long and hard about what to do about this. And in discussing with our statistician, he said, sometimes you just have to accept that the results are, they're not very bad, but they're lower than you would like. And you simply have to accept this. But given the whole picture, the rest of it is really very, very good. So I think you have to just say, we looked at the 5 questions, we thought, no, we can't lose any of these. We really have to keep them all in, and they do look like they belong together. So it's maybe just statistical artifact. So we decided we would have to just accept that particular finding, but the rest of it was very, very encouraging. So this is what the global index score looks like. And the score ranges from 0 to 100. So we called it a percentage. 0 is the worst quality of care that the woman can imagine, and 100 is the best quality of care that she can imagine. And you can see there's a very obvious ceiling effect here with the answers skewed towards the upper end of the scale, particularly moving up from 60% up towards 100%. You can see also from the coloured bars that there are sub-indices for pregnancy, for labour and birth, and postnatal, and you add these together, they become the global index score. Now, the ceiling effect is potentially a problem because it means that scores are bunched together, and it means that you've got to be very careful when you're looking at differences between subgroups, because you may have statistical significance, but it might not be numerically significant, clinically significant. And you have to be a little bit cautious about that when you have a ceiling effect. But this is very common in surveys of maternity care. As I say, you tend to get very positive responses when you survey women about the quality of care or about any aspect of their care throughout pregnancy, throughout the labour and birth, and throughout the postnatal period. Because by and large, with most women and most babies coming out alive and pretty well, women tend to give you very positive responses. So the ceiling effect is well recognized in maternity care, but it does mean you have to be a little bit cautious when you're interpreting results. It's important to note that this index score does not include the management of complications, because that really does complicate things significantly. We have to treat that as a separate sub-index score. So you have an antenatal index score and an intrapartum index score and a postnatal index score. When you sum these together, you get the global QMNC Framework index score. So that's how the score is put together. Three sum index scores, and you add them together and they become the framework indexed global score. Now, there are lots of other things that we could report. I don't have time to go into things, but we looked at continuity of care. That's one of the things that we've been looking at for a number of years. And I know that you're very interested in this too, because that's the topic of your seminar, your conference today. So we have receiving care from a known care provider during pregnancy, during labor, birth, and postnatally. And you can see that there are some significant differences here. Now, the first thing I'll say is, although I've put Scotland here, I've put UK down at the bottom, and that's because we did this online survey, and we know that people shared the survey link with people in England. So, but we don't know how many did, because we didn't ask for a zip code, what we call a postcode. So we weren't sure, but we know that some of it was UK, but it was probably mostly Scotland. What's very disappointing from my perspective is the labour scores for the Scotland or the UK, which is where you see that the receiving care from a known care provider all or most of the time is very low compared to the other countries. Ghana, not so good, better in Australia, very good in India. So that's disappointing from our perspective, because that's something that we try and encourage, but organizationally that proves to be very difficult. So there's lots of other things that we could report in terms of sub-analyses for different groups, but I haven't got time to do that today. Excuse me. So we've shown that this survey form works in different contexts, in countries like Scotland and in Australia, where there's a long established tradition of midwifery care. Maternity care is by and large very well organized. There's good tertiary care available, and it's either free, as in Scotland, or generally speaking affordable, as in Australia. But we've shown that it also works in a very different contexts, in more low resource context, particularly Ghana, where there's a much greater disparity between wealthy and poor, and also in India. So to show that it works in very different contexts is very encouraging. And it also, we found, works in terms of different recruitment strategies. So again, it was very encouraging that that actually worked. So we are saying that the validation was successful, that the QMNC Framework Index is a valid instrument for the assessment of user perceptions of the quality of care. Now, it's important to stress that that is what women say they think the quality of care is like. In time, we would like to triangulate this and produce an equivalent survey for staff, and you would run the two together and say, well, this is what the women think, this is what the the service providers, the midwives, the nurses, nurse midwives, the doctors, whoever they are, and that varies around the world. And you compare whether they agree or disagree about what the quality of care looks like. So we're offering this now to interested parties. We have a protocol for setting up studies, which tells people how to calculate their score and also advice on how to translate where this is needed. We've published the validation paper. It's in the journal Birth. It came out in October of last year. So we have 3 translations already underway in Arabic. We have a Palestinian PhD student, and she's supervised in Oslo in Norway, and that's how she came on board. So we have an Arabic translation, which is also being piloted in Saudi Arabia. We have a Chinese translation, which has already been used in a validation study, and we've just submitted a paper for the validation study in China. And we have a Portuguese version, which has been developed by colleagues of mine in Brazil in conjunction with some researchers in, or some health policy people rather, in Portugal. So we have 3 translations at advanced stage underway as well. But we have other interested parties from around the world. As I say, the Palestinian student is working with a Saudi Arabian student, and they've developed an Arabic version. The Brazil has been done, the Portuguese version has been done between Brazil and Portugal. But you can see that we've got interested parties who want to use this tool in the Netherlands, in Norway, in Germany, in Turkey, Japan, Indonesia as well, back again in Australia and again in India. We have a researcher in Kenya who wants to produce a Swahili version that he'll use in Kenya and Tanzania and Uganda. Somebody in Ethiopia wants to do it. A different person in Ghana wants to use it. We've got somebody in Peru, people in the United States who want to use English and Spanish versions, and that'll be great because that will open up a lot of other countries. And somebody in Canada who wants to do a French and English version, and again, that will open up using the tool in Francophone countries, particularly in West Africa. So we're moving into the global phase of this research now, and I'm very pleased that somebody from Indonesia's expressed an interest in doing this. So we look forward to collaborating and helping you to use this tool in Indonesia. So the next phase is to take the tool, make it a global tool, really revalidate it if you have to translate it into another languages. This will be, the whole process of translating, revalidating will be monitored by the Research Alliance. We do need to ensure that any translation and any study is robust. We also need to be sure that we don't end up with multiple versions in a different language, because that will just be confusing. So people have to register with the Research Alliance if they want to use this, but that's free. It's free to join in, that you're then part of a global network of people who are interested in developing the work of the framework. So that's all for now. Thank you very much for your time, and I'm happy to take questions.
All right. Thank you so much, Andari, for your insightful presentation. Now we are open for discussion. I will start with the 3 raised hand from participants. Who wants to give the question directly to the speaker? Anyone? You can. Oh, yes, please, Dean.
Okay, thank you so much, Tina. Thank you so much, Andrew, for the nice presentation. This is new knowledge for me. And my question is, what challenges did you face during develop these tools, and how did you overcome them? Thank you so much.
I'm very sorry. This sound quality is not very good. I'm not really hearing that question.
Okay. Can I type the question in chat?
I think if you put it in the chat, well, I'll stop sharing now, and then we can put it in the chat. I'm sorry, I really couldn't hear the question there. If I look in the chat.
All right. I can help you with her question. She asks that what is the challenges you have been through for developing this QMNC framework?
The challenges.
Yeah.
Well, the first challenge was that we were developing this, and COVID came along, and that was a challenge for everyone all around the world. So it meant that some of the things that we planned to do, we couldn't do, and that's the way things worked out. One of the challenges is about getting research funding, because although it's not expensive to do this, it does require some funding, a little bit of organization. And so I was very grateful when the Norwegian team came on board, because they paid for the statistician. It's a real shame that, for me, that people who fund research are not always very interested in pregnancy, maternity care. And that's a real shame, because if you get this right, if you get good quality of care, you get much better outcomes. You save money. You have healthy babies to start with, and you have healthier people as they grow older. So you save money in the long run by investing in good maternity care. Policymakers, people who grant funding bodies, sometimes they don't understand this. So that's the second challenge, was really about getting some money to do it. It took us a while, but we did get there. But mostly we were working relatively unfunded for this one, which is not ideal, because it does take time. The other challenge, I suppose, is the challenge with any multinational study, that you're collaborating with people in different parts of the world. Now, of course, with Zoom and Teams, we can do this much more efficiently now. I mean, 20 years ago, it was really very difficult to do this. But with Teams and Zoom, it's possible to do so much. A challenge is working with people in different time zones, that whenever we have meetings with our Australian colleagues, it's either very early at night or very early in the morning or late at night. For the Research Alliance, when we have people in America and Europe and Australia, we can't all meet at the same time, because for one part of the world, it's always 2:00 in the morning, and that's not fair. So that's a challenge, that you have to have multiple meetings sometimes if you're doing really multinational global research. But I think, yeah, sorry, does that answer your question? Is that the kind of thing? Recruitment is the other thing you have to say. We did struggle in the first phase of the validation study to recruit, that we'd been assured that we would have no trouble recruiting, that these service user groups said, yes, no problem, we've done this loads of times before, and it just didn't work. So you have to look and see, well, why didn't it work? What would you do differently? What incentives can you offer people who are advertising the study, or that you want to join the study? So recruitment is always a challenge.
Yep, I really agree that QMNC framework tools is really, really important, because we can cause effective fitness from our country, and to preventable disease, non-communicable disease, particularly. So, Dean, do you get it, the answer?
Yes, thank you so much, Andrew.
Thank you for your question.
All right, thank you. All right, we have Husnul Fadila already raised her hand. Yes, please deliver your question.
Hello, Andrew. Hello, Andrew. So
a little bit louder, please.
Okay. Can you see me?
I can see it, but your voice is very soft.
Oh, sorry. Now you can see.
Yeah, we can hear.
Okay. Symon, I'm so glad to thank you for your. I'm very eager to learn about the QMNC FE. Learn more, because I find it truly fascinating for the framework, and I would like to ask a questions. What challenges have you faced when applying the QMNC FE framework in both developed and developing countries? Do you think it can be applied fairly across different socio-economic contexts? Because in Indonesia, it's different.
Thank you.
From
That's a
your
very
country.
interesting question.
Okay,
So
thank you, Symon.
Can it be applied across different socioeconomic contexts? Well, what we tried to do in both the qualitative studies that showed that it seems to work well, but that was in Scotland and Australia, so quite high resource countries. But also in the survey instrument, which was across very different contexts, was that it does seem to work. with people who are in different socioeconomic circumstances. Now, the framework itself is a representation of the global evidence. So it's from high and middle and low income countries. So it looked at all the evidence, I mean, all of the evidence around the world. So it really did take on board and try and synthesize what quality care looks like in every context you can imagine around the world, from a high developed, high resource country with very good tertiary level care, down towards rural areas in much poorer parts of the world. Now, there's no doubt that there are challenges. So if you go, I'm involved in another study in India at the moment, and they're talking about some of the challenges in working what they refer to as the tribal areas there, which are very, very poor. And there's no doubt that you've got significant problems when you're trying to access people, to trying to run any kind of survey with people who may have literacy problems. So you have to think very carefully about how the people you hope to recruit to a study will perceive what you're doing. And in some places you have to explain, well, what quality of care. If you have women are not used to being asked their opinion in some countries in the world, women are not used to being asked what they think, because it's just expected that if you have a service, then they will like the service because they should be grateful. And we had this earlier on. I did an earlier study, a series of studies on quality of life, not care, but quality of life instruments. And we ran the study in China, and it didn't run very well, because what we found was that Chinese women in that context, in this particular place, were not used to being asked for their opinion about how they were feeling. So you have to say that, yes, there is a challenge if you're trying to run the survey in an area where people are under-resourced, where they're not used to being asked their opinion, and they may fear giving an honest answer because they think it's, we have to give the correct answer, not the honest answer. So you have to be very careful that there's no what we call social desirability bias that comes into the responses, because that is possible. And it is possible that happens in the Ghana and India groups, because the women were recruited face-to-face and they were interviewed face-to-face. Now, in that setting, it's possible that some of the respondents, some of the mothers, responded what they thought the researcher wanted to hear, and not what they said was the real accurate answer. So you have to be very careful, and you get around that, at least you hope you do, by training the researchers so that they impress on the mother that you really do want to know what you think here. There's no right or wrong answer. There's only what you think is the answer. So you have to prepare your researchers very, very well, so that they don't give the impression that they are in charge and they know what the right answer is. So therefore, that makes the woman feel, I must give the woman the right answer. So you have to be very careful about doing that in low resource settings where people are maybe not very educated or not very assertive, don't feel that they have any power. You have to empower people to give honest answers. Does that answer your question?
How is it, Husnul? Do you get it?
Thank you, Symon. And how about let's make a bias for the QMNC framework from the developed country?
Well, this is why we chose to have Ghana and India, where we had a much wider range of richer and poorer people involved in the study, because we didn't want it to be a survey that you can only run in rich countries with developed healthcare systems and well-established maternity care. We want it to run in places where midwifery, for example, is either non-existent or only very new to certain countries, as it is in India at the moment. They're just getting going, really, with developing midwifery as an autonomous profession. And it's in some places, but not in other places. So that's why we used Ghana and India. We involved them to try and get around that problem about it being a sort of, if you like, a high resource country survey. We don't want it to be that. And it's based on the framework, which is itself global. It does reflect the evidence from low resource countries as well as high resource countries.
So Husnul, how is
Thank
it?
you, Symon.
All right, thank you so much, Husnul. We move on to Raihana. Yes, please.
Okay, I want to say thank you to Andrew for an interesting presentation. I noticed that there will be protocols in applying the framework, right? So, considering the varying levels of healthcare facilities in countries like Indonesia, from community health center to secondary health center and then tertiary hospital, do you think the protocols in the QMNC framework can be realistically applied across all these levels, especially given in the differences in healthcare worker quality?
Thank you. That's a very good question. I mean, if you like, there's two answers. One is that I hope it would, but until we try it in lots of different settings, we don't honestly know, which is partly why we want to monitor how the tool is used until it gets really established, until we show that it works in lots and lots of different countries. We don't really know. So that's why we need to try it in different countries and different settings and show that yes, it works in hospital settings, but it also works in community settings. But if it doesn't work in any of those, we need to know why it doesn't and try and say, well, do we need to modify it in any way? Now, we don't think we do, but that we have to acknowledge that it's possible that in some areas, for certain reasons, you might have to modify something. We hope it doesn't come to that because that makes it more complex. And you don't want to end up with lots and lots of different versions. But at the same time, you need to know that it works. So the answer is that we will only know for sure when we try. We look forward very much to seeing whether it works in Indonesia in different settings. I mean, you're a very big country, so I'm sure you have very different settings in the rural areas compared to the cities. So it's important that we assess it in lots of different areas.
Okay, so we will find that out later after we try it, right?
Yes.
Okay, thank you, Andrew.
Thank you for your question. It's a very good question.
Thank you, Raihana. Anyone who wants to raise her hand? Raise hand. Oh, we have a question in the Zoom chat from Epiati Aini Muriana. I will read it to you. How can the QMNC framework be practically implemented in clinical setting to improve the quality of maternal and newborn care from the perspective of service user? In what ways can the domains of care organization and complication management in the QMNC framework be used to identify the gaps and improve the service delivery in maternity units?
Okay, again, that's a very good question. And that's why we're advising that when the survey is used, that you also do follow-up qualitative interviews, because you'll do the survey and you'll find what the scores are, and you'll notice that the scores are particularly high or particularly low in certain areas, that perhaps some things are not very positively viewed. And so you want to know why, and you need really then to do some in-depth follow-up interviews with a selection of respondents to find out why they answered the way they did. Because the bottom line, you're quite right, it's about identifying where care quality is not good and then improving that, because it gives you a really good opportunity. I mean, also to identify where it is very good, and you then reinforce that. You know that you're doing well in certain areas, but it should identify. And we did get areas. I mean, continuity, for example, that slide I showed you said that continuity of care in intrapartum in the Scottish data was very poor. So we know that that's some area where we need to improve. So it kind of depends on the results you get when you run the survey. You'll then find out where the areas of strength and the areas of weakness are. But then if you do some qualitative research afterwards, you can drill down and maybe really investigate what's really going on. Why was the score so low for management of complications or for continuity or whatever it was? And that, I think, you'll then get a very good rounded picture. You've got the strength of numbers from a good size survey, but you've also got the detail that you can get from some qualitative interviews that explore the results in more depth.
How about it? Abiati, do you get it? You can give a reaction in the Zoom. All
Okay,
right,
thank you.
thank you so much. Before the limited time, we open one more question from Zalfa.
Okay, thank you, Symon.
Yep.
Symon, can you hear my
Sorry,
voice?
I can't hear. Can you go closer to the microphone, please?
All right, we will wait for Zalfa.
Can you hear my voice clearly right now?
I can hear you now. Thank
Yep.
you.
Oh, okay. I'm so sorry. I using two device because my microphone is getting error right now. Okay. So actually this is my very first time of my interaction with male midwife because in Indonesia all midwife is woman. And
All right.
okay, it's really nice to see you here, Andrew. Okay, my name is Delpha, and now I am currently working a project that quite similar to your project. I have a project with Hazel Kittle from Western Sydney University, if you know her. But the focus is in maternal birth experience, but from the mother, the experience from the mother. So yes, this project is so interesting for me because you also have so many challenges, right? Because you have a collaboration with different country like in India, Ghana, UK, and Australia as well. So my question is, have you observed any significant difference in maternal birth experience between the high income country like UK and Australia that compared to another country like India or Ghana? I ask it because Indonesia is may likely share similar patterns with the other developing country, right? And so, have you been in collaboration with Indonesian people or midwife from Indonesia before?
Uh,
That's
we
it.
did get we got an inquiry a couple of years ago when we told people from the Research Alliance that we were
Oh,
doing this work, and we said if you're interested in getting a job, we hoped we would finish before now. So I'm afraid I meant to look up her name and I've forgot to look it up this morning. So I can't remember her name. She may be on this call, which would be nice. So there is a midwife in Indonesia who's expressed an interest in doing that. If you're here, please say who you are. I'm afraid I meant to look up your name and I forgot. But in terms of the difference between the high and low income, because the framework is derived from a global synthesis of the evidence, including low and middle income countries,
Yep.
In theory, the framework reflects care around the world in every setting. And the way that they phrase things was to try and make things not specific to rich countries, for example.
Yeah.
So continuity is continuity whether it happens in Indonesia or India or Scotland or Brazil. So it's the concepts are really the same concepts wherever they are in the world. The setting will be different. But what we're trying to establish, and we can only know by trying this in more and different countries, is if it really does work in every setting around the world. So that's why we have to keep going with the research to establish that, yes, this does work. If it needs to be modified, if the evidence says, look, it really doesn't work in particular settings, then we have to acknowledge that. We can't, we can't say that we've got a good tool and everybody must use it. If it doesn't work, it doesn't work. But it did work so far in quite different contexts. So there's good reason to be hopeful that it will work in different settings. But we can only know that for sure by trying.
Oh, yeah. Okay, I got it. So, have you been challenges between you send the survey in middle upper country or the low middle income country, Simon?
The survey was done in Ghana, which is classified as a low, I think still a low income country. And also in India, which is a real mixture. I mean, parts of India are very, very wealthy and parts are incredibly poor. So again, there was, even in the place where we did the research there was a wide range of richer and poorer women. So, but we didn't, they were all city-based. So again, we have to show that it works in rural areas, in less developed urban areas. So it's an ongoing question. And we have to show, if we want to know that it's a global tool, we have to show that it works really in lots of different settings.
Oh,
And
yeah.
there's just for Eviyati is asked in the comments, the chat there, look forward to the results of the qualitative phase. We've published four papers in the qualitative phase, 2 in Scotland and 2 in Australia, so they're all published. I can put the references in the chat if that helps.
Okay.
I need to look them up. Sorry, that was just
Okay, perfect.
just while I saw that question in the chat. Sorry, did that answer your question there?
Okay.
Is everything clear, Salva? Or do you still want to ask?
No, I'm waiting the reference. Wait,
I'll put the references in the
chat.
chat.
Yeah.
I just need
Yeah.
to find it quickly.
It didn't pop in my chat yet.
All right, we will wait until the Symon send the reference.
Okay, I will check it later.
All right.
So, Symon, thank you very much for your interesting material today. So I really appreciate your answer and insights that you shared to us. And it is very helpful and inspiring, actually, for my own project as well. And I'm really looking forward to learning more from you and your team also.
Okay, thank you. And did you say was it Hannah Darlan you're working with?
Hannah Dalan and Hazel Kittle. That's right.
All right. Yeah, I know Hannah. I know Hannah.
Yeah. I will see her in the end of May in this year.
All right.
Yeah,
I will
yeah.
say
Hannah is
I was
going to
asking after
Indonesia.
Hannah.
Hannah will going to Indonesia in 21, I think. Yeah.
Okay.
Yeah.
Thank you. Say hello to Hannah for me. I know her well.
Oh, right. Okay.
I'll just
Thank
find
you,
those
Andrew.
references.
Yeah. Thank you, Andrew. I will say it to Hannah.
I'm really happy that everyone can connect in this Zoom webinar. So I think, Andrew, I would like to invite you for give us your closing statement.
A closing statement. Well, it's to say that thank you. Firstly, thank you very much for inviting me to join your seminar today. You've chosen continuity of care, which is really, really important. So if you can improve continuity of care, you will be improving the quality of care, and that will improve outcomes for mothers and babies. So it's really important work. So congratulations on the work that you're doing there to improve the care for mothers and babies, because that's really important. It's the best start in life. It's a really good foundation for health and well-being throughout life. So well done in all the work that you're doing.
Thank you, Symon. So before we will end off the session, we will take a moment documentation with you.
Okay,
Everybody, please turn on all of the camera.
All right.
All right, operator, please capture this moment. All right, I will count 1, 2, 3, and then everybody smile. 1, 2, 3. All right, thank you so much once again, Symon, for your presentations. We learned a lot for today and level up. So I will give it back to our MC, Raihana. Over to you.
Okay, thank you so much, Andrew, and thank you so much, Kinanti. Before I close today's event, I would like to kindly remind everyone to follow our Instagram account at Ruang Bidan _ID to stay updated on our upcoming activities and other exciting content. And our nearest upcoming event is Master Degree Mentoring Class 2025. Make sure you guys don't miss it. And thank you once again for your active participation, and we look forward to seeing you in the next event. Bye. Thank you, everyone. Thank you, Andrew.
Thank you, Andrew.
Okay.
Have a good day.
I'll put this in the chat just now. I think I've almost got it.
All right, we still wait.
I'll just.
Yeah, keep going.
There's quite a few, so I've just getting rid of the stuff that's not.
Thank you so much for all the participants who are already joining us today.
Yes, thank you so much, everyone. I really
We are so
appreciate
excited.
everyone who came from all around Indonesia, from Maldives, from Iran. Thank you so much. And we look
How's your
forward.
feeling? How's your feeling, Rayhana?
Yeah, great. I'm so excited, right?
Yeah. Let's meet in another event.
Yeah, thank you. Thank you, Nahuda. Thank you, Wulan.
Thank you, Nahuda. Thank you, Bulan. Thank you, everyone.
Okay. Thank you. I've put the references in the chat there, so if you want to follow any of them up, they're there.
Okay,
Yep.
Andrew. Thank you so much.
We will keep forward. Thank you, Andrew.
Okay. All the very best.
Bye. Have a good day.
Okay, and you. Bye now.